Hello, everyone. Welcome to Grand Rounds on this Monday afternoon. We are so delighted to have with us one of our very own, Dr. Daniel Steinberg, who many of you remember as the Internal Medicine Program Director from 2009 to 2020. Since then, he's been serving as the Chief Patient Safety Officer for Mount Sinai Downtown, where he's already done a tremendous amount of work in terms of the overall reporting, analysis, prevention of serious adverse effects, and improving education and safety and quality for residents and faculty. He also serves as the Associate Dean for Quality and Patient Safety in GME. He's a professor of medicine and medical education at the medical school. He's a winner of numerous awards, including the ACGME's 2021 Parker J. Palmer Courage to Teach Award, which is the highest award for program directors in the United States. He lectures all over the country and was the course director for the recent Society of Hospital Medicine conference. I could go on and on, but I won't, so that he has time to teach with us. We're just thrilled that he's sharing some of his wisdom with us. Dr. Steinberg, thank you.
Thank you, Dr. Weissman. I appreciate the introduction, and it's always in the invitation. And it's always a pleasure to speak at Grand Rounds. And so the title of today's talk is called Maybe Optimizing Supervision of Trainees. And I have no disclosures. Here are your learning objectives for the session. By the end of the talk, I want you to be able to recognize factors that influence the supervision of residents, to decide how much supervision a resident needs, to implement approaches to improve your supervision of residents. And by residents, I mean that in the ACGME sense of the word. The ACGME uses the word residents to apply to interns, residents, and fellows. And so we'll be talking about all of those folks when we refer to residents. So why are we talking about this now? Well, as we all know, July 1st is around the corner. It's a very exciting time. It's a time of renewal. And it's also a time when most of us, not all of us, but many of us are moving up. We have interns who are going to become PGY2s and supervising a team for the first time. We have twos who are going to be becoming PGY3s. We have some of you, our seniors who are graduating, who are going to become fellows. And that's a chance to obviously supervise residents and students in a different role. Some of our graduates are going to become attendings. And for the senior faculty and people who have been out for a while, it's just a great time to think about our approach to supervision. It's really a journey of constant learning and revising your own approach and style. That's what I've learned through medicine. And, your own approach and style is really what I want you to develop. I'm not here to tell you how to do things. You are going to figure out what your style and approach is. Today, I hope to introduce concepts to you and some frameworks for thinking about supervision that you can use to reflect on how you approach supervision and come up with something that works for you and those who supervise. Because there's a lot of experience on the call, and I think it's important to honor and recognize that. So there's a song by Carly Rae Jepsen, which has a line in it. It's a very catchy song. Some of you probably remember hearing it. There's a line that says, "Hey, I just met you and this is crazy, but here's my number, so call me maybe." And when I heard this, this is like how I thought of really putting this talk together. I heard this song and I was thinking, boy, that really sounds like the first day of a new rotation on the inpatient wards, right? Especially in July, where this 5 or 6 people thrown together, and you don't really know each other, or maybe you maybe it's October, kind of know each other, but you never work together. And this goes for attendings as well, and you're all exchanging contact information, and there's an assumption that you can call the supervisor, or as a supervisor, the people who are on your team are going to call you, but you don't know what the norms are, right? You don't know exactly how that's going to work out. There's that uncertainty. And so Carly Rae Jepsen sort of nailed it on the head. Obviously in a different setting, more around like, social settings, but that's the origin of the talk. So, the goal of supervision really is twofold. It's to allow residents to acquire the ability to practice independently, and at the same time, ensure the delivery of the safest high quality care to our patients while trainees are developing their practice ability. And so really what it comes down to is it's this balancing of supervision and autonomy that we want to grant to residents. It occurs on many levels. The ACGME sets sort of big picture rules for supervision, structure, caps and how much time faculty have to dedicate and all these things. Residency programs design experiences carefully, tailoring schedules and such to supervision. But the critical work of supervision is done on the front lines. That's really what it comes down to. It's done by supervising faculty and senior trainees who are supervising each other and more junior trainees. And so, all of us on this call, work on the front lines, and that's really where a lot of this gets done. The stakes are high to get it right. You can see two articles on the screen. On the left, it is an example of, what happens when we, the collective we, get supervision wrong. Libby Zine was an 18-year-old New York City resident, young woman, who she died in 1984 at New York Hospital on the Upper East Side. Ultimately, it was determined that she had taken a combination of Demerol and phenelzine, which was mistakenly given to her. It was essentially a medication interaction error. In addition, she was terribly physically restrained as well, which did not help. And the outcome, gained, her unfortunate death gained a lot of publicity because her father, Sidney Zine, was a writer for the New York Times. And it just led to this outcry about supervision of trainees. And it led to something called the Bell Commission, which is the origin of the New York State duty hour rules and the rules for supervision that the ACGME ultimately adopted that we all live by today. And so we certainly don't want, and the issue was that the intern and the resident in this case were not adequately supervised. And so we certainly don't want that. Now, if we swing the pendulum too far the other way, we end up with the article on the right, which is from the pediatrics literature. But we certainly don't want to be helicoptering the house staff. That's a reference to helicopter parenting, where you're sort of micromanaging and hovering over. And the question is, do the children who are being helicoptered, or do the trainees who are being helicoptered, do they develop the skills they need to? So it's a balance that we have to strike, and it's not easy. So to me, there's a Venn diagram which comes down to what I have on the screen for you. Supervision is about people. It's about how people interact with each other. And so I think the factors that really drive supervision are a combination of what residents need, right? Each resident has a different level of ability, what residents want, and what a resident may want can be different from what they need, okay? And there are all sorts of reasons for that. And then there's what the supervisor can provide, right? So whether the supervisor is an attending, a fellow, or a senior resident, supervisors are not magically perfect people. They're humans. They have a comfort level. They have a style. They have their own confidence issues. They have their own resources and time constraints and such. All of this also takes place within a particular culture. Okay. And so culture is a factor here as well. And so we're looking, ideally, the supervision that occurs is going to be somewhere in the middle of the intersection of these three circles. But my talk here today is very much about how people interact with each other, because I think that's what a lot of it comes down to. So does supervision improve outcomes? Well, it's a fair question. We'd ask that of any systems innovation, any therapeutic innovation. So we can ask that question here. I'll tell you that the answer is the literature is mixed. There's a couple of sort of four prominent studies with their one-liners from the results on the screen there. One study found that overnight supervision of residents did not improve mortality, length of stay, or readmissions. Another found that autonomy was associated with more ICU transfer. Another found a positive or neutral effect on surgical related outcomes and increased supervision of surgical residents. There was another study, which we'll talk about in more detail, where more intense rounds by the hospital medicine attending did not reduce medical errors. And, so to me, it's an evolving area of research. The literature, I would say at best is weak to moderate. These are usually single site studies, polling of residents and faculty, lots of recall bias, underpowered studies. But even with those limitations, the literature offers us great suggestions, which we'll talk about. To me, I think the situation is the evidence may be mixed, but lack of evidence is not evidence of lack of effect. And hopefully evolving research will tell us more. Whatever we think of the literature, the ACGME, and I think our common sense would tell us that supervision is important. This is from the common program requirements. Supervision in the setting of graduate medical education provides safe and effective care to patients, ensures each resident's development of the skills, knowledge, and attitudes required to enter the unsupervised practice of medicine, and establishes the foundation for continued professional growth. So the data is mixed, but we have to do it. It makes good sense. So what's the sort of state of supervision in internal medicine and residency programs in general? On the national level, the ACGME, through their clear reporting structure, they published in 2021 their report of the their findings from the years 2017 to 2020. This was after reviewing hundreds of programs. This is all before COVID. What they found was, you can see on the left there is 31.7% of residents across the country reported experiencing or witnessing a peer in a situation with inadequate supervision. Right, so a third of residents experienced inadequate supervision or witnessed a peer getting inadequate supervision. This trend has been increasing with statistical significance in the recent years, according to the ACGME. And they postulate, why might that be? Part of it, they say, is just the incessant sort of march towards more production pressure on the part of faculty, and the important part of billing, but the fact that there's just increasing production pressure, and is that taking away faculty from providing the supervision that they need? That's one theory. On the local level, in the Mount Sinai Health System, we did a GME survey where we asked our residents in our system, and we have about 2,300 residents in our system, that same question: have you ever experienced or witnessed a peer in a situation with inadequate supervision? 13% of our residents answered yes to that question. And then the 21-22 ACGME resident survey, which many on the call just filled out, between February and April, depending on the program you're in, 90% reported receiving an appropriate level of supervision, but that's versus 92% nationally, and 2% below the national mean may not seem like a lot, but at this level of sample size, it is. And so clearly, it's an ongoing project for us in graduate medical education. Now, there are programs and pockets and areas where there are no issues of supervision, but there are also places in the system where there are. So the work continues, but that's sort of the big picture. So let's talk about this balance. We'll get into sort of how we achieve this balance between supervision and autonomy. We want to do that in a way that promotes growth, right? Because our point is, and our goal is for people to grow to the ability where they can practice independently. And so what we need to do is keep residents in the learning zone. The learning zone is that yellow middle area in the bullseye graphic on the screen. And we know from work done by educational psychologists that growth occurs in this learning zone. And where is this learning zone? It's critically beyond the comfort zone. It's out of one's comfort zone, but it's before the panic zone. Okay. And so essentially this means you want to challenge the people that you're supervising, but you can't turn your back on them. You can't over challenge them or not be there to provide support, because then they're going to panic. And if you coddle them or you leave them to their own devices with no support, they're not going to learn. So this is a visual representation of that balance we're trying to strike. Research on deliberate practice and the development of expertise across many fields, not just medicine, backs up clearly that this concept of getting out of your comfort zone is key for people in training to develop expertise. So this is our task, right? To titrate our supervision and autonomy to keep residents in this zone. So let's talk a little bit about how to do this. And, I'll point at it that it's even more complex. I showed you one bullseye diagram, but really the other thing you need to know is that every individual's threshold for each zone will be different. And so you need to be flexible in your approach. So if we start on the left with resident A, this is a representation of resident A on a floor rotation. They have their comfort zone, they have their green learning zone, and then they have their relatively big panic zone. Now you compare that to resident B on the same floor rotation. That's the one in the middle. So compared to resident A, resident B has a bigger comfort zone. Maybe they know more, they have more experience, they're just more, their level of ability is higher at that time. They have a bigger comfort zone, they have a smaller learning zone, but they also still have a panic zone. And so you can't, ideally treat resident A and resident B the same way. It really should be individualized. Now, there can be variations within the same resident. So let's follow the purple arrow to the right-hand bullseye. This is resident B, same resident as in the middle, who's now on a floor rotation where the census is very high. Now there's 20 patients every day, right? 20 patients, 2 interns, and it's like that for a week. That's never happened, right? We just had that, right? For a few weeks recently, and it happens. So a resident's comfort zone can change. Here we see resident B a little less comfortable, right? They have a little more to learn, and their panic zone is a little bit bigger in this situation. So our job as supervisors is to know who we are supervising and titrate our supervision to keep residents in the learning zone. So, trust is something we'll talk about in depth here, because to me, trust is an essential concept in supervision. It really comes down as as an attending, do you trust the resident? As a resident senior, do you trust your intern? As a fellow, do you trust the senior resident? Your first year pulmonary critical care fellow somewhere, do you trust the medical resident who's running your unit, with you, or when you're not there, right? Does the resident trust that the attending will be there to support them and is guiding them correctly, right? So it's a two-way street. And the level of trust that you establish will drive the level of supervision you provide. So really determining trust is a core competency for anybody who's supervising anyone else. I will say that it takes some effort to determine how much you can trust somebody, but it's worth the effort. So as an attending, if you realize you can trust your team, you can focus on things like teaching more, on being more of a coach rather than being so granular with the details, on higher level decision making. You have more time for your meetings and your other non-clinical activities, right? If you're a senior resident and you put in the work to figure out how much you can trust your team, and you realize you can trust your team, allows you to think a little bit more big picture, and get to report and conferences a little bit more reliably, and do the higher level things that you should be doing and enjoying as a senior resident, right? So that's the idea. And if you find that you can't trust your team or an individual person, that's critical information you need to know, because then you can step in and be more involved in the details as is needed, and you can provide better feedback. So when I was in medical school, I went whitewater rafting on the Colorado River. I think it was like between summer of second year and third year. And I was still getting used to the fact, like, in college, like all your friends are off for the summer and you can do things, right? So all together because everybody is vacation at the same time. Well, after college, everybody's working and this and that. And, the summer, the first 2 summers you have in medical school, I realized, well, all my friends weren't available. So I was like, well, I still want to go away and do something. So I just went on this trip by myself, signed up. It was great. Flew out to the Grand Canyon, and you get up at 4 o'clock in the morning. You hike down from the rim of the Grand Canyon all the way down to the base of the Colorado River. You have to start at 4 a.m. because it's like 120 degrees or something during the day. And you can only really hike in the early morning. So I did that, got down to the river, and I was by myself, and I met 4 or 5, 6, maybe 6 or 7 other people and 2 guides. And we spoke briefly, got to know each other briefly, had a quick discussion, and then we got into a raft that looks exactly like this, where we all had paddles. And we headed down the river on our 7-day trip. And I'm telling you this story here because what I had to do is I had to immediately place my trust in both the guides and these other people who I didn't really know. I'd known them for 10 minutes. And we needed to get our trip underway. And the only way to do that is to work as a team, to get in the boat and, and start paddling. And so we developed this trust very quickly because we had to. But I will say that for the first, few hours and days or so, I was still kind of figuring out, can I really trust these people? And so I was working to sort of affirm the fact that, everybody's going to be acting safely and the guides are going to be guiding us correctly. And there's actually a term for this in the literature. It's called swift trust. So it occurs in quick forming temporary teams that must engage in complex, high stakes, interdependent work. And this is from some really prolific authors in patient safety. Some of you will recognize the names below. Carl Wick, in particular, he was one of the people who developed the high reliability principles. And so, I had to engage in swift trust on the rafting trip. And swift trust is really pretty similar to what has to happen for an inpatient team, right? A newly formed team in the CCU, a newly formed team on the floor, a newly formed team in the ICU, et cetera, right? We have to trust each other initially to some degree, just because the work has to get done. We have to make the starting assumption that all of us can and will do what we're supposed to do, right? So that the work gets done. Here's the key. As the supervisor, we must then work to verify the trust, right? To really understand how much we can trust people, okay? So that initial swift trust that happens to all of us, it's just a starting point, and it's an assumption we make out of necessity, but we can't take it too far, okay? So let's talk about how to do this. How do you determine trust, more specifically? Well, there was a great study in academic medicine in 2008. This was done at 3 urban teaching hospitals in Canada, which described the main ways that attendings make point of care competency and trust assessments. And so what they did was emergency department and general internal medicine ward teams were observed. They were also given video vignettes related to supervision, and those were presented to participants. The participants were then asked how they would handle each of these, video vignettes, and this was recorded and themes were elicited. And so they did this study for 19 attendings, 13 residents, and 4 students. And again, this is a typical, study, med ed study from the literature. There's all sorts of limitations, and the studies are not large, but nonetheless, they're interesting. So what they found was that this group identified 4 key elements of trustworthiness, and they're on the board there: knowledge and skill, awareness of their own limitations, conscientiousness, and reliability and truthfulness. And so, the point here is that it's about a lot more than just knowledge and skills. I think, sometimes we're all very focused on what are other people's knowledge and skill level. But I want to point you to these other 3 things. which I think we all think about, but maybe not as explicitly. To me, actually, the only quality, the only one of these four that someone can't have, and I will still trust them, is knowledge and skill. If someone's not truthful, I'm not going to trust them. If someone's not conscientious and reliable as best they can be, I'm not going to trust them. If someone's not aware of their own limitations, I'm not going to trust them. If they don't have all the knowledge and skill that they perhaps might need to, should have at that point, that's okay. I can work with that. But the absence of the others is very challenging. So I'm going to suggest to you that as a supervisor, you want to create what's called psychological safety. And this concept is well defined in the following quote, I think. It's the belief that individuals can engage in interpersonally risky behaviors, such as disagreeing, asking questions, and reporting mistakes without negative consequences. And so in order to properly titrate your supervision, you need to know what a trainee's abilities are, what their concerns are, what their worries are, what their fears are. You need that honesty from them, so that you can tailor your supervision. You also need that honesty so that you can ensure patient safety. Okay, and in order for residents or any trainee to reveal these things, they need to feel that psychological safety. So how can you do that? Well, a couple of suggestions are to say things to your team or to an individual that open the door to being vulnerable and expressing your limitations. Here are a couple of examples. You could say, I see our service is really busy now with 20 patients. Tell me what your experience has been with managing such a large census. How comfortable are you with things? What are your concerns, right? So you're sort of hinting that the situation is challenging. It makes it easier for someone to say, yeah, I've never really done this before, or I'm concerned about this or that. Another example, treating a patient with this condition can be tricky. They are often very sick and have multiple complex issues. Have you encountered this type of case before? What has your experience been? So, these are ways to open the door. The goal here is really, for you to move your trainees, wherever you're supervising, from self-protection and image management to problem solving and authentic engagement, right? We're all very worried about how we're going to look, right? Am I going to look like I know what I'm doing? Am I going to look like I'm in charge? If only when you strip that away in the right way, when you make people comfortable with letting you know what their weaknesses are and their worries are, only then will they really be able to engage authentically, and honestly, and everybody gets more out of it. Everybody gets more out of it. So you got to create that psychological safety. It's really important. So how do you think about determining trust? What types of things? There's a concept called the entrustable professional activity, EPA, from medical education literature. An EPA is just, as the first bullet point says, it's an essential task of a discipline that an individual can be trusted to perform without direct supervision in a given healthcare context once sufficient competence has been demonstrated. So they're just, as it says, they're descriptors of work. Do you trust, you're a senior resident on your floor rotation, you have new interns, do you trust the intern to admit a patient? Does the fellow trust the resident in the ICU to run a family meeting? Does the attending trust the intern or resident to discharge a patient? These are all things you can think about in a focused way and evaluate. Recognizing a sick patient. Do I trust my student? Do I trust my resident to look up the answer to something they don't know? Have they demonstrated that? Do I trust them to escalate? So you can frame your determination of trust around the EPAs that are most relevant to your practice, right? If I haven't spoken to my intern for 2 hours because I've been in conference and other things have gotten in the way, do I trust that they're going to stay on top of the to-do list, et cetera? So there was a study in 2015 which helped us understand how faculty develop trust in residents. This was done at UCSF and at the University of Pennsylvania. It was interviews with 45 or so hospital medicine attendings. And the narrative responses were coded into themes. It's about half men, half women, average age of 7 years in attending. So pretty representative of, of general hospital medicine faculty. And they found 3 key ways that faculty determine trust in residents. They're on the board: clinical competency and leadership. Here's a quote: "I pay very close attention to what the resident is doing, how they seem to be handling the aspects of both providing good care while being a good supervisor. Comparison with a standard or self. Everything that I would have done for the patient, the resident is doing." Or direct observation, how they present themselves at rounds, if they have a clear sense of what's going on, what they're worried about at the bedside rounds, if they ask the appropriate questions, if they're concerned in the appropriate way. So, I mean, to me, this validates, what I think a lot of us probably do. I certainly do these things. I'm sure many of you do these too. And so it's nice to see it show up in the literature. Look, again, the study's not perfect. This is a study where faculty are remembering what they do, which is different than observing them in doing what they actually do. And so there's the recall bias. That being said, it's an interesting study. The same study identified barriers and accelerators of trust. So some of the barriers are if there's professionalism issues with anyone on the team, other team dynamic issues, people are not getting along for some reason. Schedule asynchrony is also a barrier, right? So the resident switches on this day, the intern switches on this day, the attending switches on this day. Programs try to compensate for that. But when that doesn't go perfectly, that schedule asynchrony is a problem. Also, there's also all sorts of reasons that we would all acknowledge are good for schedule asynchrony. Residents out for 2 days, and a covering resident is there because the resident's presenting at a national meeting, right, or is going on a fellowship interview, right? These are things that happen, but they can cause that interruption of trust. Accelerators of trust: engaged trainees, strong communication, no surprise here. Things that acted either way would be a high workload. Okay. Again, this is the concept of high workload as an accelerator. Is that concept of swift trust. You got to trust each other because you got to trust each other. And then supervisor experience level can go either way. Again, supervisors are not magical, perfect people. They're human beings, and sometimes the characteristics of the supervisor, of the attending, or of the resident or of the fellow get in the way of ideal supervision. We'll talk about that a little bit more. So, the study also identified sort of 3 starting points for trust. The first is you can start off with a high level of trust and less supervision. See how that goes. That's sort of leap of faith attitude. You can start at a low level of trust, just the bare minimum that you need, and provide more supervision. And just see how that goes. That's sort of the trial and error. And then, in some situations, to be perfectly honest, you're not sure what you should do, and you just sort of have to make your way along. I mean, some situations are clear. You can trust people a lot. Some situations you can't, and some situations aren't so clear. They're more nebulous. So, I think my advice here is just to pick a starting point, what you're comfortable with, but be open to adjusting as you go. And this concept of being flexible in your approach as you go, altering your level of supervision based on what you observe in your trainees is really important. Okay, because that's how we get the most specific high level of supervision. The attendings in this study, interestingly, those who said that they were able to establish the right level of trust for their teams experienced less anxiety, better team dynamics, and they felt that they could be more of a coach. This is by their own perception. So I think that's valuable and worth noting as well. So, as we go through this slide, I want you all to think about who you are, what column you might be in, or whether you're in the middle here. And so this is a study from academic medicine, which looked at the role of attending experience and how that affects supervision. And so, what the study did was interviewed a number of attending physicians with various level of experience. It was essentially, and then validating those themes through discussion with residents themselves. So they interviewed early faculty, interviewed more senior faculty, asked them how they supervised. Then they took all those themes and ran it by a group of residents and said, what do you guys as residents, what do you folks as residents see as the characteristics of early versus more experienced supervisors? And here they are. Early supervisors tend to be, and I'm going down the column on the left, early supervisors, early faculty tend to be more granular. They focus on trainee task completion, right? Where the lab's ordered, where the lab's checked, are the orders correct? They are on the side of more supervision. They draw on their own recent experiences as a resident, right? Like the new attending is going to draw on what worked for them as a senior resident. The new, subspecialist may be drawing initially on how they did things as a fellow. You're still sort of in that mode, They're a little less confident in their own clinical skills, as we all are as we start our career as faculty. And they're generally less confident in their ability to assess trainees, as opposed to an experienced supervisor, which this study found to be more holistic, to focus on resident qualities like leadership, again, lean towards autonomy, being more of a coach, drawing on their own experience as a supervisor, having more of a global sense of trainee abilities and relying on this, knowing where errors tend to occur. These types of cases, the residents tend to make mistakes. So I'm a little more careful, in my supervision here, or, discharge is a high risk area, or, what have you. And again, experienced supervisors, last bullet point, they were flexible. So, the people that I admire most are the senior, leaders or clinicians who can operate at, 30,000 feet at the big picture, really mega level, but who also can come down to sea level, if you will, to ask about a detail if that's necessary. And experienced supervisors have this flexible ability, right? They can be that big picture coach, but you know what? They also know how to check if the potassium is being repleted correctly. And they also, know how to go over the discharge summary carefully and understand exactly, specifically, precisely how it should be written. Because if they need to do that, then they know that they can. So again, this is for you to reflect on, and I think I certainly have moved from the left side of this slide, to the right side of the slide over a period of years. So I think, this is a nice sort of, mirror to look in for us at different times. So let's talk about some techniques for determining trust to inform your level of supervision, some specific techniques. So I'll ask you a question. Which better informs your trust determination of a resident? Okay, if you're an attending or you're a senior resident, think about an intern. The first is the resident can describe to you how to call a consult, or you observe the resident calling an actual consult, right? So I think most of you would pick the latter, right? Direct observation of competence is what we call that. You watch them doing it. And this is nothing more than Miller's assessment period, which I know some people on the call are familiar, on the Zoom are familiar with. And it really just talks about the fact that the highest way to assess an outcome is the does, right? Can the trainee do it? Can you see them do it? Whereas the lowest level is knowledge, right? A multiple choice question, or they can tell you sort of what to do. So as you are assessing trust, always try to see what your supervisee, if you will, can do, okay? And find ways to observe that. So as the residents know, and many of the hospital and many of the faculty, the hospital is certainly one way we do that in the medicine residency program here is a brief oral case presentation. This slide, so I've given this talk at many places, at other institutions and national meetings. And I've designed this slide really for an external audience. because I know everybody on the call kind of knows what it is, certainly the seniors and the hospitalists. But I talk about this because this is really, something that I think we do, which is really great. And so this is, a call, the format of which is the phone call to the attending at the end of a call shift, right? This is to the hospitalist. All the admissions are presented. Why are all the admissions presented? Because that relieves the resident from worrying about, well, am I going to look weak if I present this cellulitis case? You've got to present every case. That's the rule. We just take it out of your hands so the resident's not worrying about it, right? It gives them that permission to just present everything comfortably. It's senior residents only. This is not a call that interns should make. It's supposed to be 3 to 4 minutes, and the expectation is really to focus on synthesis of the data and a problem representation of the case, right? That's what we're looking for as attendings. And this is a good way to see, does your resident or does your fellow, or if you're a fellow or a resident, does your intern sort of, can they put the case together into its essence? Do they really know what's going on? And you can use that to titrate your supervision. So I recommend everybody do this. Certainly the hospitalists do this, but you can do this at any level. Spying is another great technique, okay? The medical education term for this is called backstage oversight. That's how it appears in the medical literature, med ed literature, but many of us just use the word spying because it's kind of fun, right? So what is that really? Well, here's an example. This is a study from the Journal of General Medicine, Journal of Graduate Medical Education from 2017, attending physician remote access of the electronic health record and implications for resident supervision. Okay, so this was at the University of Chicago, survey of 59 attendings 1 to 2 weeks after an inpatient rotation. It asked them how frequently they checked the Epic, which is what they were using, remotely when they were on service. And remotely did not mean in their office. Remotely meant specifically from home. After you're done with your day, you get home. How often do you log on and check the resident admission note or the progress notes about what's going on with your service, on a call evening? And look what they found. 92% of the attendings said that they discovered information not relayed to them by residents during discussions they had. So it was, pretty high yield in terms of discovering new information. 54% of the attendings reported making immediate management changes via call to the on-call team. And so this is, you sort of, chart, people have all sorts of terms for it, chart lurking or whatever it is. It is effective. And I think it really, it adds a great level of supervision. It adds an additional perspective on cases. And some of it is just the human element of you have another person looking at the details and you're going to pick things up, right? So it's high yield, but it requires time and energy. How many days can an attending go home, and spend, 30, 40, 60 minutes? The average here was 60 to 90 minutes a day doing this. Can you believe it? How many attendings can do that every day? I don't know. That's for everybody to decide. And at the resident or fellow level, you want to do some of this as well. But how much you can do, it depends on how much time you have. Like I said, that original Venn diagram comes back to what you as the supervisor, have in terms of resources. But it is effective. It is effective. Now, again, we have recall bias, and these are not clinical outcomes. These are just perceptions. So with that noted. Another great technique is just to be a fly on the wall. So here's a sort of generic, nursing station house, sort of like a combination nursing house staff workstation. It's a great way to learn about how your team functions is just to sit there in the resident room or whatever work room and observe your resident leading the interns, instructing them. Observe a handoff, right? Listen to an intern or a student or a resident call a consult, right? Watch how they interact with nurses or social workers, right? All of this gives you a tremendous amount of information and helps you understand how much you can trust them. It also, you'll get insight into their own awareness of limitation and their humility. And it's just a very high yield thing to do. So I recommend that. So this is a classic study from the med-ed literature called Page Me If You Need Me, the hidden curriculum of attending resident communication. And really the study addressed the question, how likely are residents to call the attending in response to common phrases that attendings say as they leave for the day. And so phrases and clinical scenarios were presented to residents, and they were asked how likely they were to call. So you can see on the left, the first bullet point, residents were much less likely to call an attending when they were told, page me if you need me, versus I want to be called on all patients you admit or have a change in status. And that was clearly statistically significant. The phrase, page me if you need me, that sets up the resident to worry that they're going to look weak. The phrase, I want to be called on all cases you admit, right? That sets a rule and it takes the decision away. It's just like, and this is really why we structured, the end of call attending, called the end of on-call phone call to the attending the way we did, right? And so you have to make the residents feel comfortable. And so probably they feel more comfortable when they're just told, they have to do it. Now, no better than page me if you need me was, you're a strong senior, but don't hesitate to call me with any questions. I don't think that's such a bad thing to say, but apparently, people don't feel comfortable with it. So this stuff is very tricky. Very interesting was a scenario where a patient suffers a pneumothorax as a complication of a thoracentesis done on a medical floor. Now, 85% of the attendings polled said they would want to be called immediately about this, but only 31% of residents said that they would call. And that was statistically significant. So clearly there is a disconnect. And a lot of this is driven by, by residents worrying about their image, worrying about how they're going to be viewed if they reach out for a question. And so again, it comes down to establishing that psychological safety, making people feel comfortable reaching out. Another really great study was from Kathleen Finn, who's a colleague of Dr. Berger's and mine up at Harvard. This was called The Effect of Increased Inpatient Attending Physician Supervision on Medical Errors, Patient Safety, and Resident Education. And this was actually a randomized controlled trial. So as I've mentioned, the data, the med-ed literature is sort of weak to moderate in methodology. This was actually a really nicely done randomized controlled trial. And so this was done at Harvard at a 1,100 bed academic teaching hospital. The control group, in the control group, the hospital medicine attendings saw all the new patients, new admissions with the team, but just ran the list on the old patients. So bedside rounds on the new admissions, and then into the back room, ran the list, card flip on the old patients. The experimental group in this trial was that the attendings saw the new patients, but then also saw all of the old patients on the service at the bedside with the resident team. And what they found with that more intensive rounding approach was no decrease in adverse events or near misses, no decrease in length of stay or ICU transfer or death. However, there was a clear decrease in residents' sense of autonomy, and that was statistically significant. So, to me, the way I interpret this study is that it certainly offers no mandate for hospital medicine attendings to see every patient on the service every day with the team on rounds, right? You're going to still see, as an attending, you're still going to see every patient every day, but you don't need to see every patient with the entire team every day, because it hasn't really been shown here, at least, to move the needle enough to justify it. I think that an intermediate approach, a flexible approach, is probably a good way to apply this in practice. So, for example, pick a point to start with your new team, and if the team's functioning well, you can trust them, then you can alter your approach. Again, it comes down to flexibility. So overnight supervision is sort of a particular focus area within supervision. And again, here the evidence is mixed. Okay, so the Haber and Catanalotti studies, were certainly interesting. Haber in 2012 found that the nocturnus led to an increase in attending contact, okay, for transfers, adverse events, invasive tests without affecting resident perception of autonomy. The Catanalotti study in JAMA was interesting as well. This was actually a question that was administered with the in-training exam in 2017. So every internal medicine resident in the country who took the in-training exam that year answered this question. It was 23,500 respondents. And so that's pretty good data. And they found that residents who worked with a nocturnist reported always having adequate supervision more often than those who did not. So that's interesting. And then there's the Gonzalez study from 2015, where overnight academic hospitals did not improve mortality, readmissions, length of stay, or ICU transfer, and the revenue increase was modest. So, again, the literature is sort of mixed here, but I think we all in MedEd feel that it's a good idea. And certainly most of the country is doing that. This is from 2017 from the National Program Director study, our survey, who handles on-site overnight supervision, hospitalists in 65% of the programs, critical care or ED physicians, 20 to 25%. And, in 2017, 21% of programs had no overnight supervision, but I strongly suspect that that has changed. That was part of the reason why this question was added to the survey. What's the nature of the interaction? Well, 45% of places, all new cases are discussed. And that's that rule-based thing to make residents feel comfortable. 34% resident discretion, and then in 12% of cases, they're around for supervision, but they don't present new cases. For those of us who try to plan overnight supervision, overnight attending supervision in any setting, whether this is the ICU or the CC or the general medicine floor, the reality is no hospital is going to pay for an attending physician to just teach and supervise overnight, okay, without billing. It's just not the way the world works. I wish that were possible, but it's very hard to sustain that model. There can be a good start. It can start that way, but eventually there needs to really be a business model. And so that's the reality of it. And some of us are concerned more about that, than others, but it's good to know. So here are my take-home points for you. Supervision is driven by what trainees need, what they want, and what the supervisor, which is you, can provide, given their own style, comfort level, and resources. The learning zone is beyond the comfort zone, but before the panic zone. Determining trust is key. There are various ways to do this, which I discussed and suggested. We want to establish psychological safety and move trainees away from image management. Reflect on how your own level of experience affects the supervision you provide. Don't say page me if you need me. You got to come up with something else. There's no clear evidence to support an attending routinely joining resident rounds on all old patients. Despite mixed data, overnight supervision is important, and most importantly, be flexible in your approach. Titrate your supervision to your learner, your trainee, your team in this situation. Thank you very much. I'm happy to take questions.
Okay. Thank you so much, Dr. Steinberg. We can open it up to questions. Feel free to put your questions in the chat or take yourself off mute. Anyone in the audience with questions? I actually have a question, Dr. Steinberg.
Yes.
Thank you. Not so much a question, but just a comment. Thank you so much for this very informative talk. I think all of us can apply this to every level of training, especially with July right around the corner, to the rising PGY2s, rising PGY3s. And I think to us as chief residents, there's definitely a learning curve. And I think with every level of training, as you proceed in your career, we definitely go from being a, becoming an expert. I can say for myself that even going from PGY1 to PGY2, I thought I was an expert PGY1. And then when I got to PGY2, not so much an expert. So thank you so much for this informative talk. I think there's a lot of take-home points for all of us that are moving on in our career, and even for our graduating PGY3s that are starting fellowship and becoming hospitalists. This was very important. Thank you.
Dr. Steinberg, maybe I don't know if you have a response.
Sure.
Well, I was going to ask a quick question.
So
So
no, I just say thank you, Manira. I totally agree. I completely agree.
thanks for this. I mean, I think it's so relevant not only to residents and academic faculty, but as you know, we've spent a lot of time talking about leadership in general, and this is like exactly those same skills that managers in all in all arenas need to think about. I did want to go back to one sort of early slide. If I remember correctly, you said that something like 31% said that the trainees were in a position of not being supervised, but then 90-something% nationally say supervision is adequate. I didn't totally understand the distinction between those two numbers. Is that because of a lack of trust and people not feeling comfortable to report on it, or what? Where do you think that discrepancy comes from?
It's a great question, and if I had the answer, I'd be a very rich man. I mean, these are the things that we puzzle over in GME. I think part of it is that it's two separate surveys at different points in time with different questions in different contexts, and so I think they're both valid results because they're both large sample sizes. So how do you reconcile them? I think the first question is, have you ever seen a resident, a peer? And it may be that they're asking about, maybe that they're getting people to focus more on a one-time, occurrence, whereas it may be that the survey, which had a higher sort of compliance rate of 90%, maybe people are thinking more generally. But one of the things we toil over in GME is, how do residents, what do they think about when they answer these questions? And so I agree, it appears a little discordant, but at the same time, I have confidence in both of the results. I'm not sure that's a great solution. I'll just go back to something, Manira, that you had said very quickly. My transition from intern to resident was the biggest transition I ever underwent in my career. It was graduating medical school, starting clinical rotations was great. Finishing the clinical rotations, graduating medical school was great. Starting internship was challenging. Becoming attending was challenging, but nothing compared to going from PGY1 to PGY2 in medicine. So I completely agree, and I remember that. And I think this is why we talk about these things. The more you pre-think about, what your approach is going to be, the more, you rehearse it in your mind, and the more tips you go in with, the better off you can be. Dr. Raghavan, I agree with you for sure that a lot of these concepts are certainly transferable to the ambulatory setting, as you well point out, particularly trust. Absolutely.
I think one question in the chat, Dr. Kwok, excellent talk. Please elaborate on flexibility some more.
So, I think our responsibility, as supervisors is to help train people who we are supervising. And if you have a one-size-fits-all approach to supervision, well, I just round, I always do it this way. I round on every patient every day because that's what I do. And that's just what I do. That's a very you-centric approach, right? My goal for us here is for all of us to figure out how we can understand what our trainees need individually and as a team, and meet that need with the appropriate supervision, giving the autonomy where they deserve it, and giving them more supervision where it's needed. But you gotta, your approach should not be, I try to not make it a me-centered thing. But if I'm getting too rigid, then I know that I need to reevaluate. So I see we're at the top of the hour, a minute over. I'm happy to hang around. I know people are busy.
Excellent. Thank you so much for joining us, Dr. Steinberg.
Thank Thank you, Dr. Weissman, and
Yeah.
thank you, Dr. Aslanova, for your help.
Thank you, Dr. Steinberg. Always a pleasure. Thank you, everyone.
Thank you.
Thank